This is part 2 of the concept of elimination on bowel and bladder. This will be referring to the concept of bowel elimination particularly. This is Dr. Fells, and I am doing the audio recording for fecal elimination. Please refer to your theory guide for the pages to read and the unit objectives. Just a little overview of the anatomy of the large intestines and rectum. Remember that the large intestine begins at the cecum, and as we move to the ascending colon, it's going toward the top of the body. You will go into the transverse colon, which moves across over to the left side of the body, and then you will notice that the descending colon goes down toward the bottom of the body, and it would go into the sigmoid colon, and then we have the rectum and the anus. And if you look at the next image on this slide, you will see that that detects internal hemorrhoids and external hemorrhoids both. Defecation. We'll start with diet. Diet can affect defecation by the types of foods that you eat. Some vegetables can cause an increase in flatulence and or loose stools or constipation. Some vegetables such as asparagus can lead to a green stool. Fluid intake, of course, can help reduce the chance of constipation, so we should encourage our clients to drink plenty of fluids unless they're on a fluid restriction. Activity increases abdominal muscle activity so that it can move gas and increase peristalsis, which helps prevent constipation. Psychological factors can affect constipation because clients can be afraid to defecate, sometimes in public places or say after surgery, because there's pain when they defecate. Some defecation habits can be a factor in how people defecate, because some people tend to put off going to the bathroom, so they're too busy or they're not near a bathroom, so they just put it off. Medications can affect how people defecate. Opioids will cause constipation. Diuretics can dry out the stool if the client is not drinking enough liquids. Diagnostic procedures that we should be aware of are such as a colon prep may cause a high increase of watery stools because they're trying to clean out the colon, and so the goal is to flush out the colon so that when the doctor looks into the colon, he doesn't see any stool that disrupts his view. Anesthesia and surgery can cause either a sluggish stool from anesthesia or a blockage if a person had a surgical procedure like a colonectomy. Pathological conditions could be like a mass in the colon that would block the ability of the stool to pass. And pain can cause constipation. The patient does not want to defecate because it's too painful, either from hemorrhoids or from constipation itself, because it causes lower abdominal pain. In this next slide, you will see that there are pictures of different types of stools. The color can mean different foods that were eaten. The brown stool is pretty much the normal color that stool should be because of the bile that's produced in your liver. A green stool could be from foods that you ate, particularly those dark green leafy vegetables. Or a green food coloring can also do that. Yellow can be a greasy, foul-smelling stool. It can be from malabsorption of fats. It can also be from celiac disease. A black stool can mean that you're you have an ulcer in the upper GI tract. The higher it is, the darker the stool, the lower the ulceration in the GI tract can mean that the stool will be more red or bloody in color. The light color stools or clay color stools can be a lack of bile in the stool, and blood-stained stool or red stool can be from hemorrhoids or a cancer in the intestinal tract, etc. An alteration in elimination, one can be diarrhea. Diarrhea can be caused from certain foods or certain disease processes such as colitis, IBS diarrhea type, Crohn's disease, or even just excessive laxative use. There are clients or patients that have that insist on having numerous stools per day, so they use a lot of laxatives. They're almost like hooked on laxatives, so that can cause a problem with diarrhea. Gas can be from certain foods like cauliflower, cabbage, broccoli, Brussels sprouts, or it's difficult to move gas after surgery, so you could have a higher gas content from a surgical procedure. We try to get people up and move them so that we can move that gas along their intestinal tract. Constipation can be from certain foods. Sometimes cheese will do it to people, sometimes chocolate. It depends on the individual. Everything is very individual. Chocolate could cause diarrhea in some people. Opioids, medications for pain that can cause constipation in people. And decreased mobility definitely causes constipation, lack of fiber, and lack of enough hydration. In this slide, we see an example of a stoma. A stoma is a surgical opening into the bowel. We want the stoma to be slightly red and moist in appearance. We don't want to have active bleeding or have it be purple. Stomas right after surgery will be somewhat more red than later on. There might be some edema or swelling associated with the stoma right after surgery. And the locations of the stoma will definitely influence what the character of the stool is. When the stoma is in the ascending colon, because that area of the colon is right after the small bowel, you are going to see a more liquid stool. When the stoma is in the transverse colon, that stool may be slightly more formed. When the stoma is in the descending colon, you will see a harder stool out of that stoma. And when it is in the sigmoid colon, it could be almost normal, characteristic of when the client would have had the stool from their anus, because it is so close to the anal opening. So on this picture, it just shows you where the stomas could be located. If you can imagine that the stoma is in the ascending colon, you would see that on the right side of the client. If it's in the transverse colon, you would see that maybe mid area of the client, and the descending colon, it would be on the left side. The sigmoid colon, it would be in the lower left side of the colon. The locations definitely influence the characteristics of the stool, as we talked about in the last slide. There are different types of colostomies. One is called a loop colostomy. This is where a loop of bowel is brought out to the abdominal wall and supported by a plastic bridge. There's a divided colostomy where two edges of the bowel are brought out onto the abdominal wall but separated from each other. There is a double barrel colostomy, which looks like a double barrel shotgun. That is sort of how it got its name. The two ends are sutured together, and It's to relax the colon just for usually a shorter period of time with the thought of bringing it back together later on. On this slide, we are going to just go over different types of ostomy management. The stoma and skincare are extremely important. When the client or the nurse is changing the ostomy appliance, the patient themselves or the nurse should assess the stoma to make sure that there is not any active bleeding, to make sure it is not excessively edematous, or make sure it's not purple in color. Skincare is very important because the fecal matter is very irritating to the skin, and it can cause erosion of the skin around the stoma, cause infection, and cause eventually more surgery to be done to remove that area, and maybe moving the stoma because of severe irritation. The appliances are usually brought to the patient by a stoma nurse, and most facilities will have a nurse that does help measure where the stoma should be for the physician before they do the surgery, and will help pick out the type of appliance that fits closely to the stoma so that the stool does not irritate the skin around the stoma. This slide is all about the lifespan considerations for fecal incontinence, constipation, diarrhea, etc. Fecal incontinence is something that can happen as we age due to possibly surgeries of the bowel or surgeries of the prostate and our bladder, because the nerves that surround the prostate and the bladder also can be those same nerves that affect the sphincters in the colon and the anal and rectal areas, so that it can cause a lack of the ability to hold the stool back. Excessive use of medications, as I was saying earlier, there are clients that feel they have to have bowel movements a few times a day because they have to have an empty colon at all times. That will keep their weight down. So sometimes they use laxatives to keep their weight, lower. But in all, it doesn't usually have any effect on that. Cognitive impairment, such as dementia or Alzheimer's disease. These clients forget to go to the bathroom sometimes. They might feel the urge, but they forget about that urge very quickly, and so they forget to go to the bathroom. Radiation exposure or therapy can cause scarring and damage to the sphincters in the anus and the rectum. There are times when patients need radiation for cancer in that area, so it scars those sphincters, which causes an inability to hold the stool. And limited toilet access is something that also can be something that will affect the client. Sometimes clients cannot get to a bathroom quickly enough. They may be on the road and traveling somewhere and not know where bathrooms are, or sometimes if they're in the hospital and they're ringing the bell for the nurse to come and bring them a bedpan, sometimes the nurses are busy and can't get to them right away, so they can also have problems with holding their stool or trying to get up and go to the bathroom by themselves, which may cause them to fall. Some diagnostic tests that you may be involved in helping with a client. A culture and sensitivity is used to determine what kinds of bacteria may be affecting their stool, especially in cases of diarrhea. And it also indicates to the doctor or practitioner what kind of antibiotic might work best for that bacteria that's affecting their stool. Ovum parasites is one that is used in the case of diarrhea in many cases, particularly where they might have been exposed to something, possibly in another culture, or in an area where they might have picked up something. Um, Hemoccult slides are to determine if there is blood in the stool. Often we don't see blood with our eye, but it can be detected by using a solution over the top of the smear that we put on these occult tests, and then it'll turn it a certain color, such as blue, which will indicate that there's occult blood, meaning that it's not visualized with your naked eye. Other types of tests to diagnose problems with the colon. One can be an abdominal obstructive series, which is some X-rays in the sense of when clients are unable to defecate, they might have an obstruction, and that is one test that can be used. A CAT scan is another test that can be used. Often clients will get dye injected into a vein, which will highlight areas in their colon, which makes it show up better on CAT scan, so they can see if there's an obstruction. Magnetic resonance imaging is done with an MRI, and that also, like the CAT scan, will show up any kind of masses, even if they're very small. The main safety factor that you have to remember with putting any client in an MRI is that magnetic resonance will cause any metal to be pulled towards the magnet, so you cannot put a client into the MRI area with oxygen tanks or wheelchairs, or have any metal on their body that could be attracted by the magnet, because it could severely hurt them. There could be severe injuries. This slide is showing you the different ways of doing an enema. One type of enema is a Fleet's enema. That is done with a small ball that you can see over on the right side of the slide. It distends the colon and increases peristalsis. It has a medication in it, so it also helps eliminate stool. If you're giving an enema with a enema bag, you should make sure that the enema is no hotter than 100 degrees Fahrenheit. The warm enema, though, will help loosen the stool a little bit better than a cooler enema. The enema bag should be 12 to 18 inches above the level of the client. The patient's position should be in the left lateral Sims position. Don't forget that you should always lubricate the tube when inserting an enema into someone's anus. And also remember, don't insert more than 4 inches. Never force a tube if you cannot see the anal opening. If there are hemorrhoids and you cannot see the opening to the anus, then you should not force anything. Just hemorrhoids, though, does not preclude you from giving an enema as long as you can see the anal opening. Fluid is instilled by gravity when you're using an enema bag. You lower the solution to slow the flow, so that if the patient is having too much cramping, it can slow it down and cause less cramping. Once the enema, whether it's a Fleets or fluid enema, you should try to see if the client can hold the enema for 5 minutes, because it will help it work more efficiently. And then when the enema is finished, you would offer them a bedpan or a commode next to the bed, or help them into the bathroom. Remember to observe the stool when the client has passed the stool for color, consistency, odor, and amount. This slide is just pretty much straight out of your book, and it's showing you the different types of solutions that can be used for enemas. Hypertonic solution draws the water into the colon. So the adverse effect is that you can lose some sodium that way, and We don't want to deplete sodium too much for the client. They could become, confused, etc. So you should be careful with those types of enemas. Hypotonic distends the colon, stimulates peristalsis, and softens feces. There could also be a fluid and electrolyte imbalance with this one. Too much water can give them water intoxication, which is, just no electrolytes in the water. It's just an excessive amount of water. Isotonic solution distends the colon, stimulates peristalsis, and softens feces, just as the other one does, but it can cause sodium retention as well. And soap suds enema is used to irritate the mucosa and distend the colon, but it can also irritate mucosa. Mineral oil enema can lubricate the feces and the mucosa. Some nursing diagnoses that you may want to consider for bowel problems. One is constipation. You can put that it's related to a hard stool or an inability to pass a stool. Some of the AEBs would be, of course, patient specific, but might be no fiber in their diet, might be an inability to ambulate, to get up and move their stool. Risk for constipation, you would list the risk factors, which could be the use of opioids, again, the inability to ambulate. They may not have constipation at that point, but it could happen if they cannot ambulate. And diarrhea related to liquid stool. The AEBs would be, possibly that they take too many laxatives, or that they have too many fruits and vegetables, and they have a possibility of diarrhea in their family history. Other considerations would be that they might have pain, they might have tissue injury in the area of the rectum, such as a fissure. A fissure would make it very painful to defecate. Hemorrhoids also make it very painful to defecate at times and or cause bleeding, particularly if the client is conscious. Should ask you for a laxative. Cathartics, one of the cathartics that is that has a good use of moving the stool is one called sorbitol, and basically cathartic just means to purge. Antidiarrheal medication would be Imodium. Patients should not use too much Imodium. An anti-flatulent medication would be Beano. That's an over-the-counter type medicine. And that ends this lecture on bowel elimination.